Thank you everyone for coming tonight to tonight's OTEP Clinical Case Webinar. Tonight we have Dr. Michael Maclean presenting on palliative care in people with drug dependence. I'd like to begin by acknowledging the traditional custodians of the country and lands on which we meet and recognize their continuing connection to land, water, and culture. So these are just the registrations for tonight. We have a lot of people from Hunter, New England. Thank you very much for coming, as well as a good mix of regional, metropolitan, and people coming from other states. And these are the roles, a lot of general practitioners and pharmacists as usual, but I also did see in the registrations some people who have some background in palliative care. So yes, these are the registrations for tonight. And before we begin, I do just want to point out that you may have been familiar with the name OTAC, but we have a new name, which is OTEP. We're the Opioid Dependence Treatment Education Program, and we just changed the name to reflect the broader educational offerings that we have. And we also have a new website and a new email. If you do search up the old website, you will be redirected to the new one, so don't worry, and emails will also be forwarded to the new email. But I just wanted to point that out if you hadn't seen the email from OTEP yet. So for the clinical case webinars, these are monthly webinars that we hold. They're recorded, so if you ask any questions or share any information, just make sure it's okay to share, and we will issue e-certificates that you can use to claim for CPD points if you're interested. And again, they're recorded, and we put the recordings on the OTEP website along with a copy of the slides. And I just want to point out that the OTAC scholarships round 3 is open, and there's more information on the OTEP website. And this is for general practitioners and nurse practitioners in New South Wales working in private work settings. And just a quick slide on housekeeping before we begin the presentation. Please keep yourselves on mute. If you want to ask some questions during the webinar, please feel free to put that in the chat. We have Dr. Sharon Reed with us who will be monitoring the chat. And if you want to ask any questions at the end of the webinar, then we'll have a little bit of time for that. And I'll turn it over to Michael now. Thank you.
Great. Thanks, Jess. Good evening, everyone. So this talk is titled Palliative Care in People with Drug Dependence. And the idea of this presentation came to light working with the palliative care teams across Sydney Local Health District. And the idea kind of arose from difficult clinical cases, challenging clinical cases I've come across in drug dependence with patients either under palliative care or with sort of terminal trajectories with serious illness. And sort of just the lack of information in the literature, lack of guidelines in this space. So I hope this presentation is really clinically focused and can help people navigate this area when they do come across these sort of challenging clinical scenarios at that kind of intersection between drug dependence and patients with serious terminal illnesses. So I guess to begin with, I just wanted to get a kind of poll on how many people have actually treated people in this area for drug or alcohol dependence in the palliative care setting. Great. So it looks like there's a significant proportion of you all who have definitely come across this. Maybe this is part of your clinical work, maybe it's fairly common. And there's also a good proportion of you who have not experienced this. So I hope this will help prepare you for those situations that you will come across in the future. So we'll stop sharing and we'll just get into the objectives of the presentation. So it's just really about recognizing the different approaches to managing these unique sort of clinical situations, also some sort of ethical challenges around that too. And just being aware of the language that we can use to communicate patients under palliative care as well. And we'll also just cover some case vignettes as part of these sort of clinical case webinars I've come across that illustrate some of these points. So I guess just to begin with, there's many different definitions, but a general consensus and definition is really palliative care is for people any age who have been diagnosed with a serious, typically incurable illness, which will likely ultimately lead to their passing. And palliative care services are really aimed at improving symptoms and quality of life in this area. So a distinct subset of this, which is end-of-life care. So end-of-life care is typically for people in the last months to weeks of life, and it is still aimed at symptom control and improving quality of life in those times, but it's often also around about planning. So whether that takes place at home, hospital, in a palliative care unit, a hospice, or a residential aged care facility. It's important just to also bust some myths just very early on. We've all heard of sort of movies, radio, oh, a patient gave me a doctor gave me 5 months to live and I'm here 5 years later. So the palliative care is really not about giving accurate prognoses. It's always a case by case basis. We can give, palliative care can give general trajectories. Different specialists can give general trajectories on prognosis, but it's always a case by case basis. Another one is that palliative care is only relevant in end of life, those last months or weeks. It's actually not true. Patient with a long prognosis or trajectory, palliative care can still be involved early on to help manage symptoms and plan and improve quality of life. And there's also emerging evidence now that actually palliative care can improve longevity or prognosis in certain conditions. For example, certain lung cancers, it can actually improve survivorship by a couple of weeks to a few weeks. And this slide is really just looking at different illness trajectories and how they differ in functional decline. So you can see there on the y-axis that, say, for a cancer trajectory, functioning can be relatively well preserved until the terminal phases of the illness or in end-of-life care. Whereas you might see with something like dementia or different organs such as COPD, you might see this fluctuating decline with sort of peaks and troughs in functioning. And this is quite important in our patient population when we think about what supports they might need in functioning, particularly with different illness trajectories. So what about this interface here with co-occurring addiction and terminal illness? So what we're finding is there's an increasing co-occurrence. So this is becoming an increasing common clinical picture, something I'll see all the time at Royal Prince Alfred or at Concord. There's this emergence of patients living longer and longer due to advances in our treatment, say for cancer or any other illness, say lung illnesses, COPD, liver, cirrhosis, those sorts of things. Survivorship is extending, and then therefore, a lot of these illnesses can be seen as chronic illnesses in and of themselves rather than immediate life-threatening illnesses. And on the other hand, addictions now actually meet the WHO definition of a palliative care condition. They're often life limiting. We know patients who inject substances have a shorter lifespan. So you can see there's a huge overlap in actually these two different clinical pictures. And we see there's a changing face of palliative care patients. So this is a study published in the British Medical Journal, and it looked at IV drug users in England. And it found that on this y-axis here, you can see proportion of deaths from different causes. So you can see as people age, they age out of their 30s, 40s, 50s. If they're an IV drug user, they're less likely to die from a fatal drug poisoning and more likely to die from other illness such as respiratory cancers, circulatory diseases, liver diseases as they age. And what this reflects is that they're basically adjusting themselves and dying from similar illnesses as to the general public, which means that they're living or they're carrying on these comorbid conditions well into advanced age. That means that we're increasingly coming across this in the palliative care setting, and as drug health clinicians, we're being increasingly asked to consult on these patients. This is not to ignore the fact that illicit opioid use, IV drug use, is still associated with a 15-year increased risk or earlier mortality or death than the general public, although that gap is reducing over time. So if we look at the clinical syndrome with palliative care versus with addictions, we see that there might at some point become a terminal diagnosis, whether that's a cancer, a cirrhosis diagnosis, a COPD diagnosis. Then as that illness progresses, it may enter an end of life, so deterioration phase. This is typically weeks, so from the month stage with end of life to weeks for the deteriorating phase. And this can be associated with acceleration of those symptoms of that particular organ dysfunction, also fatigue, hypersomnia. It often could be anorexia and anhedonia, loss of interest. And there often is this support that is required, so palliative ADLs, maybe taking medication, shopping, maybe it's managing basic ADLs as well. So needing support for that, which is important in outpatient population. They may not always have close supports. And then in the terminal phase, this is often a period where a patient might be bedbound. There's changes in breathing, urinary output, decrease in peripheral perfusion. Sometimes this can be followed by a terminal, so-called terminal delirium, visual, auditory hallucinations, paranoia, irritability, fidgeting, twitching. These can be associated with biochemical abnormalities as well. And then if we link that with patients with substance use and look at that timeline, we can see that there's a certain high risk period there with a terminal diagnosis. So if a patient's in remission from a substance use disorder, maybe they're stable on opioid agonist therapy. That terminal diagnosis can be a really high risk period for relapse or worsening of a substance use. Something to be aware if we've got a long-term client that all of a sudden is diagnosed. We might want to see them more frequently or check in with them. It's also a time when they might be prescribed some opioids as well, which is important in our practice, especially if this has been an OTEP webinar as well. In that terminal phase, though, this is really important. You see patients and they can have this overlapping syndrome. So what might look like the normal natural process of dying can also be medical complications, but it can actually also be an intoxication state. It can be a withdrawal state. And to just keep those diagnostic blinkers on for those distinct clinical conditions and actually treat it if necessary. So where does palliative care occur? Well, it actually occurs in palliative care units, palliative care wards, hospices. The average palliative care unit stay in New South Wales and Victoria is approximately 10 days. And patients typically present there for end of life care. So these are patients in the final weeks or days. But the remaining set of them present for symptom management. Maybe their prognosis is relatively long, in which case they might need to get on top of shortness of breath or pain issues. There also might be some discharge planning, so disposition, are they moving to a residential aged care facility or not? Additionally, it might be around prognosis or assessment. How stable is their illness? Is it deteriorating at a rapid rate? Do we need to put extra supports in place? Palliative care can also take place in main hospital wards through consultation, much like our services sometimes with drug and alcohol, we can provide a consultation service. And it can also occur in outpatients as well, in clinics and at home. And this is typically nursing led, but not always. Now, we can already imagine some of the barriers that our patients have in accessing specialized drug and alcohol services, accessing at the pharmacies, accessing nursing, specialist nursing care around drug and alcohol. So these patients who also have a terminal diagnosis, they're facing those same barriers, but also accessing specialist palliative care services. So regional and rural settings, access is really a big issue. They will also suffer from unstable housing, finances, maybe a chaotic or unsupportive family unit, lack of friends, close neighbours. And the supports from palliative care are limited, much like our own for drug health. We struggle with supporting patients in the community. We're not always well funded to do outreach. Or if it is, it's typically reserved for the more severe substance users. And I think this is an important point to remember. Supports in palliative care are going to be max 1 hour a day from nursing. So if they're requiring palliative ADLs, help with showering, those sorts of things. What are they going to do for the other 23 hours? So it's good to just have that idea in mind if palliative care involved, what the max supports they are able to provide are. And there's also this kind of interface too around confusion about what is the goals of care. And then conversations around death and dying with our patients can often be very triggering. Who is sort of responsible for having those kind of frank and open discussions? Is it palliative care? Is it us? And how do we navigate that? Maybe we haven't built up links with palliative care services. Maybe they're tenuous. And I guess the concerns from, say, addictions clinicians, pharmacists, nurses, psychologists, doctors in this area is what is our role? Is it really around harm minimization with a limited prognosis, or do we just say, oh, it's not important anymore because there's something more pressing happening? Another concern is, well, what is our role? Maybe if we're prescribing buprenorphine or methadone, what are our responsibilities in this area? Being unclear about that. Maybe the palliative care physician or maybe the GPs also prescribing some opioids on top. Maybe they haven't sought approval. Maybe they don't think it's relevant. And then there's also the sort of limitations and scope for both palliative care doctors as well as addiction doctors as well. So they have their own concerns. So palliative care physicians often wonder, is addiction even an important or relevant goal of care? They also have a concern about even broaching, I've spoken to palliative care physicians, even broaching the topic of dependence. They're worried about worsening that rapport. They're worried about stigmatizing the patient. And then final one is that it complicates medication discussions. They may think, this is a common one I've heard, they may think broaching conversations around, say, opioid prescribing or benzo prescribing, they're worried that that will worsen the rapport and that the patient may not want to come and see them because they're fearing they may be stigmatized. So they don't even know how to broach that discussion sometimes. And
Michael,
yes,
there's a couple of questions in the chat
sure.
from Steve, and it was going back a couple of slides when you were talking about the high risk period.
Yeah.
And Steve says, is it a high risk period or does it occur occasionally? I have not seen this occur, though I often have seen fear of it amongst treating professionals.
Yeah. So unfortunately, we don't have objective data on this. All I can speak from clinical experiences and how our clinical responses to this in outpatients and in inpatients is we consider it a high risk period, but objective data is lacking on that.
And also the Steve also makes a comment, our patients also lack access to GPs to support the palliative care team. Our local team prefers to advise GPs who actually do the prescribing for the patient, and our drug and alcohol service has sometimes filled this gap.
And sorry, what was the question at the beginning of that statement?
I think it was just a comment really that our
Yeah.
patients also lack access to GPs.
Yeah, that can be a difficult one, and especially if the palliative care service is based around using a GP to manage patients as well. Yeah, I concur. Okay, and so just moving on, so the current guidelines, yeah, they offer limited guidance in this area as well, and this is a concern. So in the States, studies have shown that 50% of palliative care specialists report substance misuse or diversion as a challenge in their practice. And in ambulatory oncology patients in the US, 46% of patients, this is just general patients, oncology patients in the ambulatory care setting, 46% of them have a positive UDS for non-prescribed medications. Are they using illicit substances or illicit prescribed medications on top? And then 39% of it, on the other hand, have negative urine drug screens for prescribed medications. This raises the possibility of diversion. And also, like I mentioned before, survivorship is increasing. So this is just becoming an increasingly common problem. And patients can even have emergent substance use disorders, which aren't necessarily always picked up in the palliative care setting. And unfortunately, the DSM-5 text revision doesn't necessarily help us in this area. It sort of diagnosing and teasing these things out. And why is that? A, a raft of changes happen with a terminal diagnosis and in that terminal phase, to the point where a lot of these diagnostic criteria are almost impossible to disentangle. Take diagnostic criteria 5, recurrent substance use resulting in a failure to fulfill major role obligations. Well, if a patient's taking oxycodone non-stop to get on top of pain, they're not going to be attending work, they're not going to be going to school, maybe they're deteriorating. It doesn't make sense to even apply that criteria, if not very difficult to disentangle it out from their illness process. And of course, if we're prescribing opioids for chronic cancer pain, tolerance and withdrawal, just going to be a given. So maybe we could use a prescription opioid use disorder criteria, like they do in pain clinics. So I guess I just wanted to make that point. And if we sort of divide these out into the patient, the palliative care team, and addictions, we look at a patient's symptoms. Palliative care approach it around the physical, emotional, spiritual. Palliative care physicians, feel free to jump in at any point or at the end if you want to sort of correct any of this. I've sort of run this over with different palliative care physicians in Concord. They're okay with it. Whereas we take approach, we address symptoms around cravings, withdrawal, and then, the patient, their experience of our approach to their care and treatment, while palliative care focus more on quality of their life, whereas we're focusing more on harm minimization and recovery. And what does recovery mean with a terminal diagnosis? And then I guess there's this sort of uncertainty a patient has around a diagnosis and this sort of variable prognosis and different treatments being offered. Palliative care tends to focus and manage on those life-limiting illnesses, where we're kind of focused more on preventing, mitigating those life-limiting illnesses. So let's get to our first case. So this is Miss Karina. So Miss K, she's a 62-year-old female. I met her on the respiratory ward. She's single. She's on disability support pension. She's got severe COPD. She's on home O2, nocturnal CPAP. She's also on methadone maintenance therapy, 50 milligrams via public clinic. She was brought in by ambulance when her home oxygen malfunctioned. She was admitted under the respiratory team for management and control of that type 2 respiratory failure. She's fairly stable in methadone maintenance therapy, even though I was at a lower dose. She hadn't used heroin for a while, and she had managed to give up smoking as well. She had had frequent input from palliative care teams when she had been admitted in the past with panic and shortness of breath related to her related to her COPD. And palliative care were involved around trials of lorazepam to manage that panic and shortness of breath. There'd been multiple attempts to reduce methadone in outpatients. And there'd been previous unintentional lorazepam overdoses. Patient become quite sedated, especially with the methadone on board. So quite a precarious clinical situation. And lung function is just continuing to deteriorate with that functional decline as well. So respiratory team requests, can we optimize her methadone? Can we get it to a better place where she's not so short of breath? Maybe respiratory function can improve. So how would you approach the situation? So we could delay the methadone down titration, retrial, reducing it in outpatients. Maybe we could suggest increase the dose of lorazepam, maybe just focus on symptom control. Maybe we could force down titrate her methadone to preserve lung function, give her Nixoid and see how it goes. Or we could advocate for prolonging the admission to allow for a microdose transfer to buprenorphine. So how could we approach this?
So I've pulled up the poll, but there was a question in the chat from Ian asking what was the thinking around multiple failed attempts to reduce methadone?
I think the thinking was there previously in the community is that she had had so many presentations to hospital and respiratory distress that maybe if we could reduce the methadone, we could improve her lung function, improve her functioning somewhat, and reduce those risk of unintentional overdoses. I might add to this case too, this was previously a patient on high dose methadone, so she has been somewhat successful in reducing methadone step by step over the past couple of years. Great. So, absolutely. Look, so most of the poll responses, can we show the poll now? Yep. Share results. Yeah, absolutely. So we decided ultimately to go with option D, and the outcome of that was it was successful. So we did a 7-day low-dose buprenorphine initiation or microtransfer. Lung function did improve over the course of admission. And on discharge, the patient's HOMO2 didn't even necessarily need to be used throughout the day. Lung function improved quite dramatically. And there's always this concern, this latent concern, especially patients with trauma histories, that the methadone is kind of inadvertently acting as this sort of sedating agent for suppression of sort of PTSD type symptoms. So always concerned about that, always concerned about insomnia. Fortunately, in this case, it didn't seem to be an issue, though I have seen that quite commonly. And I guess this point, just to run it home, the health consequences of what we do are far reaching just beyond purely stability around opioid use disorder. It can have real impacts on lung function, switching from a full agonist to a partial agonist. So it's quite successful, and it was quite important to advocate for that rather than just, increasing lorazepam, managing symptom decline. This is a really interesting study from Switzerland, and it looked at patients admitted to palliative care unit compared to patients who are admitted to palliative care unit who have substance use disorders, excluding, say, nicotine dependence. And what they found is that patients with substance use disorders typically were younger, so they tend to be 5 to 10 years younger than the general population admitted. So that's reflective of patients dying younger who have substance use disorders. But their primary complaint, you can see it on the graph here, their primary complaint in green is that their main problem tended to be pain. Whereas you can see with patients admitted to the palliative care unit that don't have substance use disorder, tends to actually be more around fatigue, lassitude, anergia. So it's just an important point to remember, especially in our area, prescribing and managing patients with opioid use disorders. Pain typically is the main symptom. So just moving on to the next case.
Oh,
So,
could I interrupt a bit? Sorry,
yeah,
Michael. There's a little bit of discussion here in the chat. I don't know if you can see it about just before you leave this part. Discussion about, given palliative care, people usually use opiates for symptom control management for end of stage COPD. Why not use the opiates in the form of methadone earlier potentially, rather than the buprenorphine? So that's the gist of it. Is that right, Ian and Steve? Yep.
yeah, yeah. That's a really good point, and I guess especially if pain was a major issue for this case, we might think a full agonist might be more helpful in the circumstance. The main issue the previous patient was dealing with was shortness of breath, which were leading to recurrent presentations. So this was just really an opportunistic microtransfer to improve lung function by switching over to a partial agonist. And I guess that's the important point, which is that each patient, case by case, even though they're on a palliative trajectory, we still have a role in potentially improving their lung function, potentially improving their survivorship, thinking outside the box rather than just thinking, hey, we need to just manage these symptoms. Why not get on top of the actual illness that's driving these presentations and decline? So that was kind of the rationale behind that microtransfer. Hope that answers.
Could I jump in?
Yeah, sure.
That as I've written, I've had a patient that was sort of kind of similar to this presented patient. And when she was swapped onto buprenorphine, her wellness declined considerably, and her relaxation, her ability to breathe improved when she was returned to her usual 120 of methadone. So the buprenorphine transfer can go either way. And I also wish to point out that you use the term partial agonist in terms of buprenorphine. It's a partial agonist in that it doesn't trigger respiratory depression, but it's not a partial agonist in terms of pain relief. Buprenorphine's an effective analgesic in increasing doses as high as you care to go, in my experience, and in published experimentation.
Sure. So my understanding is that buprenorphine is a partial agonist at the mu opioid receptor, so there's a good chance patients may experience increased pain with a
But that statement's focused on its effect on respiratory depression and euphoria and other factors. In fact, it's documented. There's published findings on its effective analgesia, and indeed in our pain relief patients, buprenorphine's a better pain reliever than oxycodone, for example. So I think it's really important to dig into what we are talking about when we talk about partial agonism.
Yeah, sure. I guess just with that case there, the important point there, and I understand that you had a different clinical scenario there with different outcomes. The important point there is buprenorphine has a ceiling effect on the respiratory system, whereas methadone does not. So it's always different, especially at different doses of methadone, but we would generally expect less compromise to the respiratory system on buprenorphine. Okay, so moving on to the next case. So it's Mr. Young. So he's a 51-year-old male. He's under the outpatient palliative care team with metastatic bowel cancer and opioid use disorder. He's currently injecting heroin 2 to 5 points daily, so quite a significant use disorder, and recurrently presents to the emergency department in pain crises from sacral nerve root compression and bowel obstruction, secondary to the metastatic bowel cancer. He frequently self-discharges soon after admission due to inadequate pain management and opioid withdrawal, and he leaves before ablative radiotherapy or colonic stenting can be organized. So quite a difficult clinical challenge to manage and sort of stabilize this patient on a palliative trajectory. They're actually on Norseman patch already, and they had some endone as well prescribed through their GP. So the call from the palliative care team was, can you help us with this patient's withdrawal and pain to prevent this discharge so we can stabilize this patient? Very tricky. The patient wasn't even admitted, but it was expected to present. So this raises a sort of a difficult sort of situation. So initiating methadone in an opioid naive patient under palliative care, they would be looking at far lower doses, 1 milligram, 2 milligrams, maybe 5 milligrams total daily. Whereas we know in our area in addictions, we're working with much larger doses than that in terms of induction, more 20, 30 milligram range. So we do need to work collaboratively with palliative care. So how would we respond to this request? We would explain that this is a palliative care issue, sort of say this is not really our area for managing this patient despite the heroin use. Suggest maybe they contact the pain service, maybe this is predominantly a pain issue. Would we discuss the options around maybe using a full opioid agonist therapy, such as methadone, inducting them on it, and maybe clarifying the prescriber roles, palliative care versus addictions? Or maybe do we suggest that they refer the patient to drug health outpatients instead? Maybe manage it at a later date. Hopefully they present. Okay, so yeah, look, we've got most of the answers and discuss the options for full opioid agonist therapy and induction and clarify prescribing roles. So this is ultimately what transpired in this situation. Okay. So we initiated the patient on 20 milligrams of methadone. Now this was complicated. And part of why it was complicated is that this patient needed colonic stenting. They needed to go for a procedure. So they need to be nil by mouth as well. So when they came through ED, they were inducted on methadone, but complicating this, we couldn't give them oral methadone. So we switched it to a subcut injection and inducted them via that method. And we went for on the lower side of dosing. So typically do 80% of the oral dose for the subcut formulation. And we selected 20 milligrams, so we reduced it to 16 milligrams for inductions. Quite frail patient at this point, so we opted to go for a lower dose. We could have considered, say, higher doses, 30 milligrams. However, we up titrated that within a week, and this actually stabilized the patient and prevented them from discharging or self-discharging before palliative care could actually stabilize the patient. There was also some PRN oxycodone in addition, and that was discussed collaboratively with palliative care on the sort of role of that in addition to the methadone during that induction. And most importantly, this allowed time for the patient to stabilize, eventually get some rest, and also some space for the family to come along and grieve and talk to the patient and spend some quality time with them rather than sort of this chaotic IV drug use in the community. And a patient did pass away at day 11 after the admission, but the family and the patient was very thankful for the care they received from all the team and nurses involved. So in some ways, this is, success despite the sort of tragic outcome. So look, this leads to some controversies in palliative care. And, there's this sort of term called chemical coping. So it's the use of pain relief medications to relieve non-pain symptoms. So this might be to relieve emotional distress or existential suffering. There's also this term pseudo-addiction, so this so-called drug-seeking behavior, or what appears to be so-called drug-seeking behavior, but it's actually just inadequate symptom control. So, if the patient is in a lot of pain and they're injecting heroin to manage that pain, or maybe they're illicitly taking oxycodone off the street to manage that pain, well, it's going to have all the features of so-called drug-seeking behavior, but they're really just trying to manage a symptom or emergent symptom that they have as part of their terminal illness. And then there's a so-called sort of doctrine of double effect. If a patient's, say, on a PCA or on PRN opioids to manage their pain, but they're taking it in excessive quantities to the point they might become narcosed or sedated, risking their airway. Well, do we keep prescribing that medication? And it really depends on the trajectory and how far they're along in their illness. For example, if the person has a 5-year prognosis and we're prescribing excessive opioids and they're becoming sedated and narcosed on those and potentially misusing them, the doctrine of double effect wouldn't really make sense or be defensible in the circumstance. However, towards the end of life stages, use of super therapeutic doses of, say, opioid-based pain relief would be more suitable in that circumstance, despite it maybe hastening death. So that's the doctrine of double effect. And that's quite a separate issue to voluntary assisted dying. I'll not get into that today. So this obviously has implications in the end of life treatment phase rather than, at the onset of a terminal diagnosis. I think it's just important to remember too that, there's causes for increased pain and patients can be quite wide ranging. It can be everything from hyperalgesia, so, opioid-induced hyperalgesia with rapidly up-titrating opioids in the palliative setting, or tolerance, which we see in our clinical practice all the time, or maybe withdrawal if a patient's lapsed off medications. And these all exist in different neurobiological settings. And additional to that, just to added level of complexity, pain can surface in many varieties and forms, and this can form through emotional pain. Maybe there's unaddressed mental health needs, grief, pre-existing mental health conditions. This leads to a higher requirement of opioid pain relief. A second one can be more in the cultural or spiritual realm, existential. Are we addressing their pain needs and supports through, say, religious people, so priests, chaplains. There's role for existential positive psychology or treatment in that area, which is obviously going to be very difficult in the regional or rural settings. And then the so-called psychological pain, so this grief over foreshortened life. There's therapy around that too, so dignity therapy has been shown, so good evidence base. In terms of the pain approach, palliative care that I see often used the most is they look at this background pain that a patient has, and then they look at breakthrough pain, and then they see how often is that breakthrough pain occurring. Is it once, twice a day? Or is that breakthrough pain happening 3, 4, 5, 6 times a day? And that might be a case at which you would bump up, say, the background pain. For our patients, if they're on methadone, it might be that methadone or it might be that long-acting opioid that they're prescribed. And that's quite distinct from, say, incident pain, maybe when the pain comes on when the patient mobilizes, but that's not common. Maybe they're bedbound most of the day. So we typically calculate all the breakthrough pain and see how commonly that occurs throughout the day, and then that would typically adjust your underlying breakthrough background pain requirement. So that's often how palliative care will approach it. Now, this can be quite difficult for our patients because they might have difficulty with organization. Maybe they're using illicit substances as well. How appropriate is a PRN-based approach in a patient with pre-existing opioid use disorder and a long prognosis, maybe 4 or 5 years in the distance? So you need to think about those sorts of things. Maybe we need stage supplied. There's often a desire for mild somnolence, especially towards more the terminal trajectory. So mild somnolence is often quite desired by patients in the setting. And there's also need to think about sort of, are we underdosing the patient? Are they utilizing more PRNs? Is that more to achieve a euphoria or effect or a high or to prevent withdrawal? Or is it actually to treat progression in their illness and associated pain? And we also just need to think about, is there aberrant drug use on top, which is sort of complicating the picture as well. But it may also reflect under treatment too. And this makes it difficult for us. It also makes it difficult for palliative care physicians. How do they interpret an increasing PRN usage in a patient with a pre-existing opioid use disorder? We can't stigmatize the patient, but we also can't willfully sort of be ignorant of escalating PRN usage. Is it appropriate? And just think about all those different unaddressed needs, mental health, the different neurobiological pain mechanisms as well, opioid-induced hyperalgesia, for example. So opioid approaches in palliative care patients. So look, typically the PRN dosage that they use is 1/6 to 1/10 of the oral or the opioid oral morphine equivalent daily dose. So you often can calculate it to that. You can use MD Calc for that. And that's typically their PRN approach. And if it's breakthrough 2, 3 times a day, that's when you increase the background pain relief. Obviously, these measures blur out a little bit, and brought it up before around buprenorphine and methadone, that the pharmacodynamics don't equate perfectly, and we're talking about complex opioid pain receptor systems. So, like 8 milligrams of Suboxone might be equivalent to 320 milligrams of morphine, and that depends on what receptor subtype you're talking about as well, and what effect you're talking about. Similarly, for methadone, there are some conversions, and I will get into that as well. 60 milligrams of methadone might be equivalent to 300 milligrams of morphine. So we're dealing with very high doses in our patients, and palliative care aren't always familiar with those higher doses of opioid pain relievers. And then,
Michael, can I just interrupt this about some comments in the chat? And just in relation to this most recent slide of yours, Steve's wondering about the sort of role or about the use of long-acting injecting buprenorphine in the declining phase of terminal illness. I mean, a lot of these medications here aren't buprenorphine. What do you see as for the role of buprenorphine as disease
Yeah,
progresses?
yeah, absolutely. Beat me to the punch. It is in a slide coming up on that sort of emerging role of buprenorphine, especially in the terminal phase.
Mm,
And this is kind of linked in with, methadone as well. So just part of this slide here, so I will get to that. Methadone is often used as an adjunct or can be used as an adjunct in palliative care. But again, it's like those lower doses, right? So 2.5 milligrams, for example, versus, say, a full rotation to methadone. So that can be considered as well. And there's a Royal Perth protocol for that. But typically, that full rotation under palliative care from, say, a collection of oxycodone, a buprenorphine patch, some morphine, that will require admission to a palliative care unit. And they do that from time to time. In terms of buprenorphine and methadone, they've got variable abilities to abort a physiological withdrawal, and that's quite distinct from their analgesic properties, which tend to be a lot shorter. So you see that split dosing, especially with worsening pain and terminal trajectories. And then that brings into question, right, the long-acting injectables, which I'll get to. So the Royal Perth Protocol, just briefly go over this, just for the purposes of time. So Royal Perth Protocol talks about how you transfer someone over to methadone using kind of a palliative care method. So stop the original opioid, so they stop it. So quite distinct from what we do. Day one, day two, they give a calculated daily dose. So they follow a protocol. So I'll show you that on the next slide. And they give it in 4 divided doses. And then day 3 to 4, again, if they haven't loaded it, they give it in 3 divided doses. And then day 5 onwards, they give it in 2 divided doses. So they're kind of progressively reducing that split down when they're rotating from pre-existing opioids. And then they also give some short acting on top during that process, which kind of harks back to that second case I talked about. And see, these are the conversions that they do. So they use the oral morphine equivalent of all their opioids, and then they convert it over to methadone, and then that's how they follow their conversion protocol when they're switching over or doing their full rotation. So they call it full rotation. So opioid agonist patients in the terminal phase. So, yeah, we can split dose for maximal analgesic effect. That can often be quite helpful, especially if we want to preserve them staying just maybe on one type of therapy. But we also need to think about the inhibitory constant for short-acting opioids. If a patient is on long-acting injectables like a buprenorphine, right, they're on a huge dose, maybe 160 milligrams. Well, buprenorphine has a very, very strong affinity for the mu opioid receptor. And you can see this with the inhibitory constant. So the lower your inhibitory constant is, the more tightly that opioid medication binds to that mu opioid receptor. So if you've got buprenorphine 160 milligram injection Q3 weekly, you're going to get basically next to no effect from oxycodone added to that. I think that's just quite important when we're communicating to palliative care colleagues who might be unfamiliar with long-acting injectable buprenorphine. An option is at that stage is maybe we do lower the dose of the buprenorphine and add in these short-acting, much higher doses of oxycodone, typically 30–40% higher, and see how that goes. But it's always case by case. And then maybe we do consider rotating them completely to a full opioid agonist. Maybe that's morphine, maybe that's not morphine. So there's no single consensus on the best approach to this. These are our options. We can add an opioid agonist on top, but especially at those higher buprenorphine doses, it's probably going to do very little. We can split dose it. Maybe we can switch them over to Suboxone, for example, do BD or TDS dosing. We could increase the dose of opioid agonist therapy. So say the person's on 64 milligrams of buprenorphine monthly, subcut injection. Maybe we could increase that. Maybe we could get a bit more pain relief out of that buprenorphine, like the commenter had earlier on. Or we could reduce or cease that opioid agonist therapy and transfer prescribing rights over to palliative care, and they can put through an application for their opioid prescribing. But we just need to be mindful of the risks in opioid users. Are they actively injecting, for example? What are the other risks associated with that? So in terms of managing that breakthrough pain, we can maximize that non-opioid analgesics as well. So, neuropathic pain, we can manage that. We can add on, say, duloxetine, for example, non-pharmacological management, massage, occupational therapy. And then on methadone, we can actually add on other short-acting opioids. I've seen oxycodone that's got variable effect. And on buprenorphine, we can trial things like oxycodone. We can rotate to other opioids with high receptor affinity, such as hydromorphone. So we see that from time to time. Fentanyl, you can flood the system with fentanyl as well, and that can work. But yeah, we'll need inpatient admission stabilization for that. So this is how the application palliative care can do for prescribing of opioids and palliative care settings. So they need to be a relevant specialist in this area. So it could even be like a medical oncologist, for example. Sometimes there's co-management arrangements, and if the patient does have opioid dependence, they often need agreement from addiction specialists as well. And here it is. They write down what opioids they're on. It might be, oxycodone. It could be methadone, and their oral morphine equivalent daily dose. And then they pop that in there, and then that application's sent away. And it's registered on SafeScript as its own application. You can see the different indications: palliative care indication, cancer-related pain, or even chronic non-cancer related pain. And you request how long you want that PRU approved for. So look, I'll take it to our final case. I don't want to run too far over time. This one is straightforward in some respects, but we'll see what the responses are. So a 48-year-old male presents with shortness of breath related to his metastatic epithelioid mesothelioma. They're currently on fifth-line therapy, but it's got a palliative trajectory with this mesothelioma. They're currently drinking a bottle of vodka a day. They're still smoking. They're managed for alcohol withdrawal actually on the palliative care unit. They're also given some midazolam from time to time to manage breathlessness. But by the time I saw them, they had completed their detox. And now they're actually wanting treatment around abstinence. And they're actually requesting disulfiram. They'd maybe had success with that in the past, and they wanted to stop drinking. They wanted to spend quality time with their partner in that terminal phase of their illness. They're on quite a number of medication: oxycodone, lorazepam, metoclopramide, quetiapine, venlafaxine. And so the progress of the case was that the patient reported on taking a history that they had significant disulfiram reactions in the past when they drank, but they ultimately found it pretty helpful. They wanted it again. They felt AA, group therapy was unhelpful. They were open to other types of pharmacotherapy, but they were ultimately understanding that maybe disulfiram might not be appropriate, especially since they had those reactions in the past. And they were drinking to cope with fear-dying. Again, that's that existential fear, maybe potentially driving some of that pain, that shortness of breath. They're wanting to cut down, but ideally stop. They're considering naltrexone. They had heard a little bit about it. They hadn't really heard about Campril. But there was this plan from palliative care team. They wanted to set up a syringe driver. They wanted to give them HOMO2 with a declining lung function. And they had some issues. They had some GORD, they had some GI upset related to drinking, they had this sort of existential pain, fear of death. And they also had genuine, real physical pain, shortness of breath. And they had this limited prognosis. They were really wanting to optimize that quality of life. So how would you approach this situation? Suggest trial of naltrexone, suggest starting disulfiram, give it a go again. Maybe it was helpful in the past. Prescribe Campril, offer follow-up, address smoking maybe, to support their HOMO2, look into their motivations, provide some psychoeducation around symptom control. Yeah, so what are some of the answers? Great, so I think we could probably share that. So look, everyone's doing really well with the quizzes. Some of them are quite leading in the answer, quite a comprehensive plan. So yes, correct answer, or I guess what I ended up doing was C. So yeah, trialed the patient on Campril. It has an anti-anxiety effect as well. Safe with the liver, safe in terms of this patient's other medications prescribed. Now, Trixone obviously is going to be a major contraindication. Disulfiram for a patient who's declining and has liver metastasis as well. It's not a necessarily great idea either. So I guess what this sort of highlights is that, you know, times are really changing with palliative care and addiction medicine. And to just drive home some of those points, you know, buprenorphine's becoming increasingly common now. Long-acting injectables are becoming increasingly common. Palliative care physicians aren't that comfortable with these long-acting injectables, so they do need our support. They are becoming more familiar now. It's just becoming more common, especially in our patient demographic, but they do need our support, our specialist advice. And patients are increasingly needing input from both services. There's been some studies and really cool clinics. There's this one over in Ohio by Sachin et al. They did a study on it, and they actually had addiction specialists and palliative care specialists, as well as pharmacists and nurses and psychologists, priests, all in the same clinic. Pretty amazing, and had really positive uptake from that from patients. So just to sort of sum up now, here's some tips I kind of learned. These are more from the palliative care side, then I'll give more from the addiction side. You know, definitely don't use like stigmatizing language. We're all very familiar with this, but palliative care, getting on board with this, especially junior doctors coming through. Document it as it's rightly diagnosed. It's an opioid use disorder. You know, you wouldn't refer to a patient as a heroin addict, for example. You know, setting appropriate boundaries, gate leave limitations, just like we would say on a detox unit. You know, universal opioid precautions as well. Single prescriber, single pharmacy. Keep things quite simple. And then that sort of manages some of that chaos, some of that risk there as well with prescribing. And, you know, there's always this concern around PICs, and, you know, the evidence really there is a bit mixed, but it's always case by case basis. But we shouldn't stigmatize patients and say, oh, because they've got a history of IVDU, outright no. You know, we should always explore a case by case basis if PICs are appropriate, especially if they're indicated. So we shouldn't deny them the standard of treatment. And then tips from us when we're consulting with palliative care. Always consider that total pain, you know, mental health, existential pain, cultural issues. Are we managing that? Grief issues. And yeah, do not abandon those opioid precautions. You know, if patient still needs a PRU, whether it's pain or whether it's opioid agonist therapy, maybe they need an agreement from us for palliative care to prescribe it, or with GP. Always use those precautions. They need a PRU, single prescriber ideally, stage supply to some extent, some sort of supervision, some sort of monitoring, ideally biological monitoring as well if you can build that with the patient, and some sort of risk assessment around that. Just be supportive, offer our help. We're very familiar with things that they might be unfamiliar with, and vice versa. So we've got a lot to learn. And, you know, provide ongoing care. It can be quite abrupt, and I've seen this before in clinics. You know, a patient will get a palliative care diagnosis, and it's like, all right, can we quickly get them over to palliative care? They can take over prescribing rights of the methadone. That can be quite abrupt and painful for a patient who might be coming to a service for a long period of time and built up relationships. So even if we're not the prescriber, always provide that aftercare, that support. And always consider the disposition. You know, is this patient unwell in my clinic? Are they unwell in my pharmacy? I've gone for an outreach visit. Do they need a palliative care unit admission? Do I feel comfortable discussing that with the palliative care team? Or, you know, can I discuss it with them over the phone? Do they need an admission to the hospital ward and drug health look after them with palliative care input, vice versa? So it's to collaborate there. In my experience, they're always very willing to collaborate. And consider harm minimization approaches. So that's beyond just the controlled substances, the illicit substances. You know, consider other things as well. Just like with that last case, you know, this was alcohol and smoking. You know, smoking was important for this person because they're going home on O2. So we need to be really assured that this patient's safe. You know, cannabis as well. Maybe the patient really wants to kick cannabis before they get really sick, before their function really goes down. So we should always support them, patient-centered care, and recovery still makes sense for certain patients. So we should have that discussion with them. And always just anticipate difficulties with accessing a safe supply and treatment in terminal illness, especially for our patients who might have housing instability. Try and always support them with that. So 3 takeaway points. Our expertise is like really, really well valued in this space. Like we know a lot and very valued in this space. So just wherever you can build those connections, do it. Support, collaborate with PALCare, and always think about treating the total suffering from patients. We're often quite good at looking into comorbid mental health conditions. So always sort of explore those things with patients as well when we're doing our assessments. Great. So further information. So the Palliative Care Handbook in New Zealand is a really good resource. I used it in my junior years as well. ETG is great resource as well. The Palliative Care standards, this is the first time in 2024 in this first edition where they made brief mention of substance use and addictions. There's like 1 paragraph on it. There's no standards of how that should be cared for in the terminal stages, end of life or terminal diagnosis. But it's great to see that being mentioned now in the standards. So hopefully we see that developed and some guidelines developed, at least somewhere in the world. That would be good.